Hi, good morning. I'm Hillary from PACU, and I'm just going to go over some EVD training. So EVD training is because we frequently get patients that have head trauma and are requiring some external ventricular drains. And so it is important to know how to set up these drains and what to watch for these drains. One of the things that's going to happen is when the patients come out from the OR, they're going to come out with this type of drain here. A lot of times it is assumed that it's an EVD, which means it sits in the ventricle of the brain versus other spaces of the brain. It's important to look at your order sets and know where exactly this drain is. Just because it comes out on this type of device does not mean that it is in the ventricle. EVDs they sit in the ventricle to help relieve CSF, so that way you can create more space in the brain so your patient doesn't swell and herniate. Otherwise, they can also use it for subdural or epidural bleeds. Those are not in the ventricle. They do not need to be transduced, so it is important to know where your drain is placed in the brain. Once again, you can find that in the order set. If you can't find it in the order sets, you can find it in your notes. And if you do not have notes or order sets yet, it is important to contact your neurosurgeon or the neurosurgeon PA, so that way they can put in some of those notes and you can figure out how to properly take care of that drain. Okay, so going forward, we will talk about what to expect when your patient comes out of OR. Typically, they are going to be, laying down. They may be intubated. They may not be intubated. Typically, they are still at least pretty sleepy. So the first thing that we're going to do is we're going to go over to our patient and we're going to check all of our stopcocks, because again, at this point, we don't know what type of drain it is. So we're going to go and we're going to make sure that this is off to our patient. Okay. We're going to trace it all the way down, making sure that we don't have anything sitting on top of it. You don't want this drain being pulled out. And then you're going to go off to the patient this way as well. So off to the patient is going to be downward. You follow the tube all the way down. You also want to check in your bag here, because when you go to prime your drain, it's going to be important. Sometimes they'll have fluid in this collection chamber. It could be CSF. It could be whatever they use to prime the tubing. It could be blood. So what you're going to do is you're going to empty it, make sure everything goes to the bag, and you're going to close it back and you're going to start fresh. So now you know what you've done. You're also going to take a look at your site, make sure that nothing's coming up and that you don't have any crazy bleeding, swelling, anything around this area that you again would need to be contacting neurosurgery for. So once you get your drain and you know that all of your stopcocks are off, you're going to go over to the computer, you're going to look at your order sets, and you're going to figure out what your physician orders are and what type of drain that you're dealing with. So for this in-service, we'll call it an EVD, where it does actually sit in the ventricle, and the purpose is to drain CSF and monitor an intracranial pressure and ICP, so that way you can make sure that you're staying within the parameters that the doctor has set and make sure that you're monitoring your patient appropriately. Okay. So this comes with a couple of different safety devices. You can go ahead and put this up here so it's not going to fall. Actually, you're going to go ahead and undo this. You're going to put this up here so it doesn't fall like that. And then it has clips on the back. This is going to help open up your clips. And as long as you are off to your patient, you can maneuver this drain however you want, and it's not going to affect your patient. Your patient will not drain. It does not need to be level as long as all of your stopcocks are close to your patient. So then you're going to go ahead and you're going to put your drain on the pole using that. It also comes with these little safety straps on the back where they will go and attach this way and go and attach this way. Okay, normally they have a little piece on here. They will hold snug, so you have two devices to make sure that it's not just going to fall off the pole. And you want to make sure that you're not twisted all around and that you're, sitting on top of all your other wires, because again, you don't want anything to fall on this and to pull it from his head. When they come out of the OR, they will have this whole thing set up this way. They will not have the transducer, which we will do in just a moment. I'll attach here. What is important is that all of this here is going to be flushed by neurosurgery or the neurosurgery PA. So it should have clear fluid in it. It should be sterile, normal saline, and maybe a little blood tinge depending on what their injury is. But if you notice that it has no liquid in it at all, it's all air and nobody flushed it, that's something that you're going to have to end up calling neurosurgery for. That's not something that we're going to be doing. So the next thing too is that in this kit with your EVD, it's going to come with your level. Sometimes the level will be attached to the pole already. Sometimes it will come in the bag. Sometimes you will have to look for one, but it is important to have a level. If you're dealing with a subdural or an epidural drain, they don't need to be that level, they don't need to be transduced. Typically, you can take the levels. If for some reason they do have level orders, you know, keep your level, follow instructions. But typically, keeping your patient level is something for the EVD. So if you come to the back of the drain here, you will see that there is a little hole down here. This is where your level is going to go. I'm just going to push in. And then you'll notice that it is right where the transducer is. So that's how you know you're going to be level. For your patient, you are going to level to their tragus, which is the inner crook of their ear here. You can do this one of two ways. You can raise your drain up and down, or you can raise your stretcher up and down. So we'll eyeball it and see where we go. We're almost there. You can just cut it. Okay, so now that we are, again, all level, we've made sure that all of our stopcocks are closed, we know what our orders are, we can go ahead and we can start setting up the transducer, so that way we can monitor our ICP, and so that way we can correctly drain some CSF if need be. At this point, we can start getting sterile. We are going to be opening things. We don't necessarily need to put on sterile gloves just yet, but it's a good idea if you're going to be, you know, getting ready and everything, just to go ahead and get like your cap on, get your mask on, get your patient's mask on, get your gown on, so that way, you know, your patient isn't coughing on what you're doing over here, and so that way everybody's staying all nice and clean. So we'll go ahead and do that now. So we will put this on him. I'm not sure how well it will stay. Oh, he's got some good ears. It'll stay. And while you're doing all this, again, you can always educate your patient. They may still be asleep from anesthesia. If they're not asleep from anesthesia, let them know what you're doing, so that way they're, you know, cooperating with you, and you're not just kind of poking around with them and they're like, what are you doing? You're gonna cut this so that way I just go into the gown?
Yeah.
If your gown wasn't all inside out. All right, now it's time to put your gown on. Gathered all of our equipment. We are all sterile besides our gloves at this point. Our patient is wearing a mask. We also have our transducer ready to go. Once we're ready to hook up, we're gonna start cleaning. So again, we're gonna open this, you know, pop. Make sure that you got it nice and moist in there. And then you're gonna clean all around here. You're gonna make sure that everything is nice and clean, because you're not trying to have any kind of bacteria anywhere around the site. A lot of times, you know, when we're coming out of OR, we're gonna touch things. It's gonna be in the bed, all kinds of stuff. So we're just gonna make sure all of this is as clean as it can possibly get. Okay, once we know that that's been nice and clean, you know, good 30, 45 seconds, we're gonna let it sit in air. The next thing I'm gonna do while that is air drying is I'm gonna start opening some of my sterile packaging. So I will open my sterile packaging, okay? I will open my little blue caps, and I will put them in. Again, I'm still clean at this point. I'm trying to touch nothing. Drop them in. Oh, that one's gone. Drop them in. So, and if you need extra equipment or anything like that, extra supplies, you can always reach out and ask somebody. The next thing I'm going to do is I'm going to open my sterile saline. Typically, you're only going to need one flush. I bring anywhere from 1 to 3 just in case. And you're going to go ahead and you're going to open. And I like to hold this part right here, and I just keep it nice and sterile. Just like that. Okay, you can keep that top on it, that's fine. Now, since we are pretty much all ready to go, again, at this point, we can grab a friend, because there are going to be certain things over here that are not sterile that we're going to be touching. But for right now, we're going to go ahead and we're going to put on our sterile gloves, because we're going to start manipulating the transducer. So we'll take these off. our sterile gloves. And again, some people like to use their gloves as their sterile field. That's fine. I like to use the transducer kit. It's, you know, as long as you're making sure that your equipment remains sterile, it's not really that important where it ends up being. It's just that you don't touch a bunch of stuff with it. I don't know if I can find the bumper. There we go. All right, now we're pretty much free to touch anything we want. Sometimes it's good to, again, grab your friend and ask them if they can help you with this. So what you're gonna end up doing is, again, this is sterile. You wanna make sure that you're getting all the air out, all the little bubbles. Anytime you have air in your EVD line, it's gonna cause your ICP waveform not to be right, and then you're gonna end up having to troubleshoot it. So the way that this comes out, it has a couple of different valves on it here. Pretty much anything on your EVD, you're gonna want these nice blue caps. So if it doesn't have a blue cap, it's just best to change it to a blue cap. Yeah, I don't think that there's really anywhere on the device that it isn't good to have a blue cap. For some reason, these are vented caps. They need to come with non-vented caps. So, all right, so now what we're gonna do is we're gonna take this off. We're gonna hook this up, okay? You can change your caps out here if that helps you. This is gonna end up going to the transducer, so you don't actually need a cap here. This is gonna end up, you're gonna need a cap over here. You're gonna have a friend come on over and just with clean gloves, not sterile gloves, you're gonna have them remove this cap right over here. We are once again gonna take a brand new clean, sterile CHG, and we're gonna scrub the insertion site here. Scrub this little hub over here, because now we're gonna add our transducer to it, and we wanna make sure that anything that's coming up over here is nice and clean, okay? We don't want any reason, again, that any bacteria is gonna get in there. So we'll give that a few seconds to dry, 30 seconds or so. Now we have our caps. We have this off, we have it all off to our patient, obviously. We have that open. You're gonna be able to take this, it's gonna twist. So the goal here is to twist this onto here. Nice and sterile. Okay, you haven't touched anything else. This part's still sterile. Now you can turn it off to your drain here. This valve is open here. You can flush. You're only flushing the transducer right now. Okay, just enough like that. Once you get that flushed through, you're gonna turn it off. So that way you can't flush that way anymore. See, can't flush that way anymore. Nothing's going in, nothing's going out. You're gonna put a little blue cap on it. Okay, sterile. Now, before we flush to our patient, or before we flush to the drain, we're gonna make sure we're off to our patient, off to our patient. We're gonna turn this all the way over. What we're ending up doing here is we're priming all of this here so it can go into the drain. So that way we have our transducer and our whole system primed. This, from the patient on downward, should have already been primed by the neurosurgeon. If for some reason there's any error in any of this line here, that's not for us to do, that's for the PA to come out and do. So we won't worry about that. We're literally just worrying about where the transducer is flushing to the drain system. So now we're gonna go to the drain system, we're gonna flush, and you're gonna see all the little air bubbles come out, and that's normal. Sometimes you need to like pulsate, okay? Sometimes if you have little bubbles in there, you can like flick it, but we'll try, or just pulsate, yep. And we're gonna try to make sure that we get all our little bubbles out. This isn't sterile over here, but we're not really using that hand again, so. Yep. Okay, now what we're gonna end up doing is we're gonna turn it back off. And what you will end up doing is you can twist this off, okay? You're gonna have, this is garbage. This is, again, not gonna be hanging down like that. It's gonna be in the back. You're gonna put this down like that, okay? When you zero it, so now you're good, okay? you would again grab your next buddy because you're still sterile, and when you zero it, you should still be sterile. But, you know, for the sake of everything, we will have our buddy come in. They will hook up our transducer, because again, they're going to be clean, not sterile. Okay? You're going to end up seeing your ICP come up that way. Okay? You're going to zero. So the way you're going to do that is you're going to take this little guy off that way. Again, you're going to be sterile. And you're going to hit the zero button on there. And it's going to zero to atmospheric pressure. You don't need to worry about your drain at all at this point. Anything connecting with the patient or the drain, you're really just zeroing this transducer. Once you hear your second beep, see your zero show up, you're going to put this cap back on. At this point, you know, now you're going to turn it down. So that's ready to transduce now. Your transducer is all ready. So before you start messing with any of the stopcocks to your patient, you're going to look at your drain system, okay, where we just had flushed our sterile saline. All of this is sterile saline. It's not CSF. It's not to be accounted for. That's something that we did. So we're just going to empty it, dump it right into the bag, okay? And then you're going to flip it back up. It's very important that you make sure that this is closed and that you're only emptying it every hour. If you leave it open, you don't know how much CSF you're draining. CSF drainage is going to be different for everyone depending on what, you know, their mechanism of injury is. I would say that you have this little chamber here that goes between 20 and 25. You know, you really shouldn't be having like an insane amount of output like that. If you are, again, it's a reason to call your doctor. If you notice changes in color of your CSF, it was clear and now it's bloody, or you notice you were getting 1 to 2 mLs and now you're getting, you know, closer to 20, those are reasons to call your doctor. Again, it can be because your patient sat up above the drain. Maybe they weren't following instructions, they sat up and they dumped a bunch of fluid. Or maybe they're ventilated and respiratory therapy came over to suction your patient and they started coughing like crazy. So anytime you're doing any movements or you're doing any type of suctioning or you're doing any type of active care that might change the level of the bed or increase intracranial pressure, you're just gonna go ahead and make sure that your patient is clamped, okay? So at this point, our patient is still clamped because we just set this up. ICP is gonna be between 0 and 15. Everybody's gonna be a little bit different. When they first come out of OR, it may not pick a great ICP up because maybe they've drained a lot of fluid in the OR. Typically, if it was put in like emergency department bedside, you're gonna get some type of ICP. So if it says 0 or negative for like, you know, the first maybe hour or so, don't be too nervous. Call neurosurgery and let them know because of course they should know. But if you don't see a waveform or you see a 0 or a negative number, that can be normal. If you see anything greater than 15, you really should be wondering, okay, why are we creeping up so high? You know, are my waveforms appropriate? Those kinds of things. So now that we are ready to look at our waveform, what we're gonna end up doing is you're gonna trace back your lines. You can start at your patient, make sure nothing's kinked, nothing like that. You can open it from your patient here. So now you're open to drain. As your stopcock is off this way, you're open to drain, okay? And then over here, you're also gonna put it open to drain this way. So now you're at 10 millimeters of mercury, you're leveled with your drain. Anything over the pressure of 10 is gonna end up draining in there. So like I said, if he sits up above the drain, he's gonna drain more. If he wiggles down below the drain, he's gonna drain less. A good ICP waveform, when you do get one, is gonna look like this. It's gonna have your 3 notches. Okay, you'll notice that here it has most of your patients are gonna have an arterial line. Sometimes they'll have a cuff, but most of them are gonna have an arterial line. You're gonna end up seeing your map, you're gonna see your ICP, and then your map minus your intracranial pressure is gonna be your cerebral perfusion pressure. And they want that 60 or greater. That's how you can know that you're perfusing the brain appropriately. Just like, you know, your whole body is 65, you want your CPP to be greater than 60. So if it's not greater than 60, then you need to, again, start thinking about things that you can do to get your ICP down or get your blood pressure up a little bit. Sometimes they will have parameters like keep blood pressure less than 140 and you're kind of working in a tight space. But it is important to have your blood pressure parameters met just if they're having an intracranial bleed, but also to have your CPP goals 60 or higher to make sure that they are getting adequate perfusion to the brain. Sometimes they'll have like, you know, orders for medications to do, you know, to help them sedate or help them, you know, with pain, those kinds of things. And they can, you know, lower your blood pressure. They can also lower your ICP, and then it can help with your CPP being met. So you're kind of like in that fine line there. Important for us here while we're receiving the patients from the OR and they're waiting for their ICU bed, it's important for us to know how to manage the basics of the EVD. So thank you.